Everybody, we'd like to call the Health Benefits and Pension Committee to order. First order of business will be to call roll. Before I call roll, however, I do want to announce that all our meetings are being transcribed by our court reporter remotely. So as you don't see him sitting over here, he's still doing his transition elsewhere. So with that, Ms. Hopper, please call the roll.
Rob Fechner.
Good afternoon.
Margaret Brown.
Here.
Henry Jones. Here. David Miller. Here. Nicole Griffiths for Irena Ortega.
Here. Very fine.
Ramon Rubalcaba.
Here.
Teresa Taylor.
Here.
Shonda Wesley.
Excused.
Lynn Paquin for Betty Yee. Nope. Karen Greenwatch for Betty Yee.
Here.
And Mr. Chair, all subcommittee members are in attendance with Shonda Wesley excused.
Thank you, Ms. Hopper. Item 2 will be approval of November 16th Pension and Health Benefits Committee meeting timed agenda. What's the pleasure of the committee? It's been moved by Ms. Taylor, seconded by Ms. Green-Ross. Any discussion on the motion? Seeing none, all in favor say aye.
Aye.
Opposed, no. Motion carries. Item 3, executive report. Mr. Sweeney, would you like to begin?
Yes, please. Good afternoon, Mr. Chair, members of the committee. Anthony Sweeney, CalPERS team member, and happy to be with you in person here this month. I was complaining to my son this morning that I had to wear a mask all day in the boardroom, and he said, get used to it, Dad. I've been doing it all year. So no sympathy there.
None.
In my update today, I want to share some retirement trends and then give an update on some key activities in our customer services and support branch. Overall, our retirements are up about 3% looking at this time in 2021 to 2020. But if we look more specifically at our 3 sectors of employers, there are some noticeable trends in there. There's been a significant uptick in school retirements of more than 14%, and public agencies are up more than 8%. Although in public safety, those have remained fairly stable. So it's really the miscellaneous public agencies that are going up. But those increases are offset by a decline in state retirements of approximately 14.5%. And those are led by a downtick in state safety retirements of 26%. So that would be typically CHP or correctional officers. And then I look back at 2019 to compare, and we are up compared to 2019, approximately 6% overall. And the numbers are fairly consistent in the 3 groups. And then President Jones, to answer your question from earlier in the Finance Committee meeting, the total benefits paid in 2021 was $27.4 billion, as documented in Michelle, our controller's slides. And this number is equivalent to, comparable to the facts at the glance that you probably use on the website. And that number for 1920 was $25.8 billion. So that 27.4 is comparable if you use that number out in public. So very, very comparable. You're spot on those numbers. So anyway, as our members are navigating their life event of retirement, they're using our counselors, and our counselors have continued to service our members. And since January, we've counseled over 50,000 members on retirement. Most of those have been phone appointments, but as I've mentioned previously, we have had an uptick in our video face-to-face appointments. We've had over 1,000 appointments face-to-face in each of the last few months. Just a great story about that is we had a member who was retiring early to care for her elderly father. She was grieving the death of her spouse and her children moving away to college. She lived alone in a rural area and was able to take advantage of the video meeting. And she just kept reiterating how nice it was to be able to visit with these counselors face-to-face rather than just having a phone conversation. And her location and situation would have made it difficult for her to actually come in person to one of our regional offices, so it's reassuring to learn that the way we're evolving our services are meeting our customers' needs. We're also working on a broader scale. We're working on our next virtual CalPERS benefit education event, which is scheduled for next month, about 3 weeks away on December 8th and 9th. So as you know, this is a popular event where we educate the members on their CalPERS benefits. And once again, we'll host several classes and have a virtual Ask the Experts hall where the members can come in and get personalized advice face-to-face virtually with our team members. We're even doing some evening sessions, and we'll monitor participation of that to make sure it's viable and provide that flexibility to our members. Our CalPERS website has this information and the link to register. And we are looking at opportunities for an in-person CB at some point next year. So I'll report back on that when we meet early next year. As you are aware, we did complete our health open enrollment towards the end of last month. And open enrollment can typically be a challenging time for our contact center, but our team did an amazing job making this year a success, working with our partners across the organization to make that happen. Our contact center saw a 78% decrease in wait times this year compared to last, and we answered 34% more calls than we did last year. Last year, some of our wait times were close to an hour, and this year, the greatest average on any one day was under 15 minutes. So it's just a great effort by our agents and everybody else who helped pitch in to answer phones or pick up other workloads or do administrative duties. And, just everything in place to manage those efforts. So it was a great collaboration across the enterprise, and I just want to extend a huge thank you to our call center agents, as well as the administrative and leadership teams for making this happen. Our annual educational forum for employers was another milestone in October. It was a huge success, and our customer services and support branch teams were responsible for delivering 10 informational sessions and hosting over 15 booths for our employers to visit. They educated them on topics such as working after retirement, survivor and beneficiary information, proper reporting, and retirement basics. We had over 6,000 attendees just for our sessions alone listen in, and we received positive feedback from our employers who were in attendance. One of the topics that we covered in one of our presentations was SB 278, which passed on September 27th. And this bill is related to when employers report compensation for a member that is later reviewed and disallowed by CalPERS because it doesn't meet the government code. Previously, we would perform a downward adjustment on the member's retirement allowance and charge the member up to 3 years of overpayment. With the passage of 278, if the employer did not have that compensation reviewed and validated by CalPERS, they would now be liable for covering that member's overpayment, as well as compensate the member for the ongoing downward adjustment in their retirement allowance to make them whole. Our Employer Account Management Division continues to do a significant amount of outreach on proper reporting and MOU language, and has recently released an employer page on our CalPERS website to provide information and resources to our employers to help reduce any impacts. In addition, a circular letter is coming out next month to further inform our employers of the impacts of the bill and resources to assist them. In closing, I'm happy to report in general our benefit payments and customer satisfaction have been performing well, and our teams continue to meet the customers' needs in this virtual environment, and I'm very proud of those efforts. As we go forward, I won't have the opportunity to meet with you before the end of the year, so I wish you all a safe, happy, and healthy holiday season. And that concludes my report, and I'm happy to take any questions.
Thank you, Mr. Sweeney. And on behalf of myself and the committee, as you know, I've done a lot of Zoom, WebEx meetings over this pandemic, and I will tell you, the comments I've received from the members out there have been nothing more than glowing for all of the organization, but especially your staff and the call center in particular, for just a great outreach they've done for our members during this pandemic time. So please pass on our thanks to all of them.
I would do.
Thank you.
Mr. Beckner.
Mr. Molds,
How's volume there?
a little louder, please.
A little louder?
There
Better?
you go. Perfect.
Okay, I will do my best to almost shout. Good afternoon, Mr. Chair, members of the committee, Don Molds with the CalPERS Health Program. Today, you'll be presented with plan proposals and CalPERS Health Team proposals for the 2023 plan year. I want to begin by setting the stage for that conversation. As part of the stakeholder engagement process ahead of the board's decision last November to adopt the two-plan model for our PPO products, as well as the transition to portfolio rating, we committed to modeling alternative benefit designs for the PPO basic program and sharing the results of that work with stakeholders this fall. The goal was to see how changes to benefits would affect monthly premiums, as well as the amount our PPO members would pay out of pocket for their care. As we modeled various options, it became clear that even modest savings to premium would result in large cost shifting to members. So, as you see today, there are no proposals to make any changes to the PPO benefit design that shift costs to our members. There are only positive proposals to some benefit coverage areas, which you'll hear about during the presentation momentarily. We had a special stakeholder meeting on October 25th to share the modeling and collect feedback on different benefit design scenarios for the PERS Gold and PERS Platinum basic plans. At that meeting, both employer and member representatives were adamant that they would not support alternatives that shift costs to the member. So the consensus feedback at the meeting was that we should be looking elsewhere for ways to bring down premiums. That's also the recommendation from the CalPERS team. Research in this area shows that when cost sharing is high, people, particularly low-income people, frequently defer needed care. That can lead to worse health outcomes and additional costs down the road. I'll note that at that meeting, I also reiterated our goal to have an HMO or an EPO plan in every county so that members could have access to a high-quality plan with lower cost sharing. In the proposals you'll see today, we're bringing forward an EPO option in 11 counties where currently the only option is a PPO plan. If you approve that proposal and if those plans receive approval by the Department of Managed Healthcare, CalPERS will have an EPO or HMO in every county starting in 2023. Next, I want to update you on our Biosimilars First pharmaceutical initiative. Biosimilars First makes the default prescription for certain conditions a generic biologic instead of a name brand biologic for new prescriptions or starts only. That means it's not a replacement for an existing prescription a member is already taking. It's new prescriptions only. So the risk of disruption is significantly lower. In January of this year, we launched the use of biosimilars in place of the drug Remicade. We started with one drug affecting a small number of members, and our preliminary results show that the program was successful. We're set to launch the next phase in January 1st, 2022, expanding the use of biosimilars to 6 more drugs, again for new starts only. We will evaluate the program in early 2022 and continue to monitor it for success. Our goal here is to broaden the use of biosimilars to help increase competition in the pharmaceutical space and drive down rising drug costs. Next, I'll just very briefly reiterate what Mr. Sweeney said, which is that we had a very smooth and successful open enrollment period. Just to elaborate a bit, this was a complex year because we made several changes that really improved the health benefits for our members. We added new Medicare Advantage plans, had various plan expansions, and transitioned from 3 PPO plans to 2. We delivered extensive communications and saw a 52% increase in open enrollment transactions compared to last year. I want to thank our Health Account Management Division, the Office of Public Affairs, IT, and Mr. Sweeney's team at Customer Service and Support, who did, as you noted, just a terrific job this year. Finally, 2 quick items. I want to draw your attention to item 5C on your agenda today. This is our health benefits annual report for the 2020 plan year. We hope you find it informative and a good resource. I'd like to thank the many CalPERS team members across the enterprise who contributed to the development and delivery of that report. And lastly, I want to let the committee and our members know that our 2022 health plan member survey will kick off in January. This annual survey asks members to rate their experience with their plan and their pharmacy benefits during the 2021 plan year. We also use the survey results to measure outcomes and trends, members' care experiences, and their access to care. We would ask all members who receive a survey to respond. It goes a long way to helping make the health program better for everyone. And with that, I'll go ahead and stop, and happy to answer any questions that you have.
Thank you, Mr. Molds. I see no questions, but I too want to thank you and your entire team, especially for a successful open enrollment. I know you had a lot of changes this year, which is unprecedented, so we thank you and the team for all the hard work. Moving on to item 4, action item, approval of the September 14th meeting minutes. What's the pleasure of the committee?
Second?
Been moved by Ms. Taylor, seconded by Ms. Brown. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Item 5 is the information consent items. Having no request to move anything off, I would encourage you all to go make sure that you read through that. Item 6A, approval of the health benefits program proposals for the 2023 plan year. Mr. Molds.
Great, thank you. So Karen Polish, who is the acting chief in the Health Research and Administration Division, and Dr. Logan are going to be presenting. Karen will be doing the plan proposals, and Julia will be doing the team proposals.
Welcome.
Thank you. Good afternoon, Mr. Chair and members of the committee. Karen Polish, CalPERS team member. This is agenda item 6A, approval of health benefits program proposals for the 2023 plan year, and it's an action item. In 2020, CalPERS implemented a formalized process separate from the rate development process that allows health plans to propose one or more of the following items for CalPERS consideration for the upcoming benefit year: new basic or Medicare health plans, benefit design changes, new health benefit programs, or service area changes. Next slide, please. Today, I'll walk you through our timeline and each of the carriers' proposals, and then I'll turn it over to Dr. Julia Logan to cover proposals that the CalPERS team analyzed for your consideration today. I'll conclude with our next steps. Next slide. As a reminder, here's our proposal timeline. CalPERS put out the call to our carriers to submit proposals for 2023. Our health plan submitted new proposals for the 2023 plan year in August. And new to our process this year, we asked the plans to assess the impact their proposals would have on health equity. The team analyzed each proposal, and we're bringing you our recommendations today. Any approved plan proposals will be incorporated into the rate development process next year. Not every plan in our portfolio submitted a proposal requiring board approval, so while not every plan will be mentioned in today's presentation, all of our carriers remain in the portfolio for 2023. Next slide. To align with our strategic vision, we look for proposals that will improve healthcare quality, improve access, maintain affordability, and address equity. CalPERS team members conducted an extensive analysis of each proposal, including network coverage areas, the number of medical groups, group physician counts, coverage overlaps, projected administrative service fees, estimates of capitation and fee-for-service costs, and the review of benefit design changes. The CalPERS team also evaluated the service area expansion proposals through the Bates-White economic model to understand competitive dynamics. You'll recall we engaged Lee Daphne with the Harvard Business School and an academic affiliate at Bates White Economic Consulting to build CalPERS an economic model that predicts the impacts of basic plan expansions and proposals on our overall health plan premiums. The competition model anticipates member migration among plans, competitive dynamics within geographic areas, and overall impacts on geographic regions as well as statewide. I'll walk you through each carrier proposal and when it appears to be reasonable and is of value to our members and the health program based upon CalPERS evaluation. We'll start with Anthem Blue Cross. Next slide. Anthem submitted 2 benefit design change proposals, both for their Medicare Advantage plan. The first proposal is a change to the copay amounts for their acupuncture and chiropractic benefits. These copays would change from the CalPERS standard copay of $15 to the Medicare-covered standard copay of $10. The rationale for this change is to create parity between Anthem's Medicare copays for acupuncture, chiropractic, and office visits. The projected premium impact would be 39 cents per subscriber per month, or a 0.11% impact on the projected premium. Per subscriber per month, or PSPM, is the monthly premium impact on the single party rate. We recommend approval of this proposal. Next slide. The second proposal is an enhancement to the routine vision benefit to include a $100 eyewear allowance every 2 years. The projected premium impact would be $1.24, or a 0.34% impact on the premium. The CalPERS team does not recommend approval of this proposal because, in general, our Medicare members already have access to vision benefits through an employer benefit or a policy rider. So this would be a relatively expensive benefit change at $1.24 for a duplicate benefit that most of our members receive elsewhere. Next slide.
Before you go any further, Ms. Polish,
Yes.
we do have a request to speak on a question for Anthem Blue Cross. Ms. Brown.
Can we go back to page 7? Or whatever that was, one more? I was looking at the bottom of the, yeah, this one. So what Anthem Blue Cross is proposing is that everybody pay for acupuncture and chiropractic because you're going to bring the cost down by $5. So if I never use acupuncture, which I don't, or chiropractic, which I don't, I will be paying more.
Well, much like all of our benefits, the cost is applied across the population in the plan. So yes, there would be 39 cents.
Per month, per member.
Per subscriber, so that would be the single party impact to premium, so times 2 for the 2-party and times 2.6 for the family. So basically less than $1 per month.
And how many members do we have in this plan?
Off the top of my head, I don't know.
100,000? 50,000? Just curious.
Just 1 second.
We'll get you a number.
Yeah, I'm just curious. But are you saying that all our other plans charge about $10 for this copay?
Most of the Medicare plans charge $15 for the acupuncture, I believe, if
Yeah.
they have it. And they tend to shift over time as they align with one another.
So, okay, so all I'm saying is that it looks like my premium's going to go up if I never use, even though I never use acupuncture or chiropractic.
Yeah.
That's a true statement. You were already paying for it if you didn't use it, to be honest, right?
Okay, great. I just want to make sure we're not shifting costs to the members, right? That's what this one looks like it's doing. I know it's a little teeny bit, but it's.
It is not a zero.
Microphone.
Microphone.
Sorry, it is not a zero to your point. I'll say, because we have a robust discussion of every one of these and with the team when we review them, and one of the reasons that we decided to recommend moving forward with this is increasingly acupuncture and chiropractic are seen as alternative pain therapies, and so are replacements for opioids. One of the goals that longstanding we had is to reduce the use of those drugs, which, as you know, can be addictive and lead to other problems. So our clinical team was supportive of this move because it's a far superior alternative to that.
So did we do the analysis that shows that based on the number of members who use acupuncture and chiropractic at $5 more times whatever visits versus what they're going to collect in premiums, that it's a wash? Or are they going to be, are they going to be increasing their, income? Or do we do that analysis?
The analysis is that overall, so some of these effects are unknowable. We only model things that are knowable. The knowable costs associated with these are the 39-cent per member per month charge. The unknowable is offsets for pain therapy, but beyond the dollar offsets that are potentially out there, there are health benefits if you're getting non-addictive treatment for pain.
But aren't they already getting non-addictive treatment? They're just paying $5 more.
Correct.
Right. We don't expect that this would cause anybody. Do we really think that $5 is going to stop people from going to acupuncture and go get an opioid? I don't think so.
I'll let you speculate about that.
All right. Thank you.
Probably about the same as costing 39 cents to have the care, so.
To your point, there's 4,300 members in this Medicare plan.
Thank you.
Go ahead, Ms. Polish. Oh, just a second. Mr. Miller.
Kind of a follow-up on Ms. Brown's question. Do we know even roughly what percentage of our members are in that group of 4,000 or so are currently availing themselves of acupuncture?
We can certainly look that up and bring it back as
Yeah, we can bring
as a
that back.
deliverable.
Ms. Taylor.
Sorry, I just had to jump in on this. Having the choice that it's there, I think is what we're looking at here. It's, by the time the rates are figured out, I'm sure we won't even see that 39 cents. But I think having the option to have it, hey, if I had the option, I'd add massage therapy. But I think it's a great option, so.
Okay, Ms. Polish.
So I think we're back to slide 7, was where we stopped?
Yes.
Blue Shield submitted proposals for 2 service area expansions and a benefit design change. First is an 11-county service area expansion for Blue Shield's exclusive provider organization, or EPO plan. An EPO is a hybrid of HMO and PPO characteristics. The EPO plan utilizes the PPO network, but like an HMO, members must use in-network providers and hospitals, and they have set copays rather than deductibles and coinsurance. EPO plans are an effective tool in counties where it's challenging to put together an HMO network. The EPO is DMHC regulated, and we work with plans to make sure our EPOs can take advantage of the coordinated benefits typical of an HMO. In our conversations with Blue Shield, we've expressed our desire for the EPO to be as similar to an HMO as can be reasonably achieved. We currently have 2 EPO plans in our portfolio, the Anthem EPO in Del Norte County, and the Blue Shield EPO is currently in Butte, Colusa, Mendocino, Monterey, and Sierra counties. Additionally, the Blue Shield EPO will be in Lassa and Shasta counties beginning in 2022. I want to note here that the map on the original attachment and on your board books did not show the Lassen and Shasta counties in blue. The EPO is available in both Lassen and Shasta counties in 2022. You can see that we updated the PowerPoint here on the screen. You have updated maps in your folders, and we've had copies placed at the back of the room with the updated map. The 2023 expansion is all rural counties that currently do not have an HMO option. The expansion would provide an HMO-like option in these rural counties using a mix of Blue Shield's PPO network and additional contracted providers. Because the EPO plan will have much lower out-of-pocket costs than current PPO plans, it will reduce members' cost exposure. The competition model also shows this proposal will benefit rural members overall. It's expected that the proposal will not have a premium impact because the number of potential members for this plan is relatively small. The CalPERS team recommends approval with the acknowledgement that the proposal is contingent on DMHC approval. Next slide. Blue Shield is proposing a pharmacy shared patient savings program for its TRIO members only. It offers TRIO members a one-time per drug class per lifetime incentive if they switch to a clinically equivalent, lower-cost drug alternative. TRIO members will receive 1 month of plan savings in the form of a Visa gift card. This program will have nominal projected savings for CalPERS and members with no premium impact. The CalPERS team recommends approval.
Ms. Taylor on this item? Okay, Ms. Taylor, can you go back one slide, please?
Yeah, I just wanted to make sure, as the Blue Shield Access Plus EPO expanding for 2023 into these counties up here, now does that include doctors groups or a doctor that goes with it?
Well, they use the PPO network. So yeah, there are doctors and doctor groups in that network.
Okay, so they've used the network, they're going to have like a primary care physician they'll have to report to, and they'll have co-pays but no deductibles, correct?
Right, it's set up more like an HMO.
Okay, so, and most of these places, there's like one hospital. Is that it? That's what they're going to have to deal with, even if it's like a bad hospital?
Yeah, that's of course the challenge in the rural counties, which is why we have trouble getting an HMO in there, getting a network that's sufficient. And so the EPO is the current solve for that because they utilize the PPO network. So unfortunately, it is what it is in some of these counties, and what exists is what would be utilized.
And it won't impact premiums.
It's such a small number of people is why.
Right, so for Access Plus, because that was kind of one of the highest price plans we have, I believe. So if somebody has access, well, the other thing is though, will it be comparable to our PPO plans in price? So that switching over to will save somebody money and avail them better service and et cetera, I guess is what I'm trying to figure out.
Well, the PPO, or I'm sorry, the Access Plus already has a sort of a spot within the portfolio, and this is not going to change that spot. So it's not going to be significantly different from where it normally lands against the PPOs, although we do have quite a few changes happening to the PPOs. So next year is going to be generally interesting to see how everything
Right, because it's going up quite a bit, but I can't remember, I'll have to look again. I can't remember if the PPOs this coming year with the increase.
The PPOs switched to a two-plan
Right.
model in 2022 with the first half of risk mitigation implementation, and then this is for 2023, so this would be the next year.
So we're not even there yet?
Right,
Never mind.
right.
Yeah, okay. Great, thank you.
Sure.
Thank you, Ms. Brown.
Thank you. On the same slide, you said that these changes would benefit rural members. How does this impact urban members that participate in HMOs like Kaiser? And my concern is whether or not when we do these expansion, do we expect that the people in Kaiser HMOs will be paying a surcharge to help offset the cost of expansion into these new counties?
No, so the way that the health plans develop their health plan premiums are individual. So what Kaiser would be developing for their premium is related to Kaiser membership and Kaiser costs.
I'm not talking about the premiums. I'm talking about what we do, what CalPERS does in terms of the rate surcharge. People get money, give money, like everybody at Kaiser has to pay $24 more, and then everybody else in the more expensive plans gets offset.
So are you talking about risk mitigation and portfolio
Yes.
rating?
So do we think this expanding into these, I'll call them pseudo HMOs, is going to cause more costs to come out of the people who are in what I call suburban or
Right, so again, it's such a small number of people, it's difficult to say exactly what their risk profile will be and how it would potentially impact the aggregate risk number for the Access Plus EPO, but that's such a small number of individuals, we don't expect that it will have an impact.
Ms. Brown, this was why we engaged the Bates-White team and used their model. They ran these numbers, including with risk adjustment built in. They are such small numbers compared to the overall pool in Access Plus that they are not projected to affect premium.
So not even $1 out of the Kaiser people or the low cost. And it's not just Kaiser, it's the other one.
I cannot tell you that it will not be $1. I can't tell you that it wouldn't save $1, but the projection was that it would be close to zero.
Thank you.
Thank you, Ms. Polish. Continue.
I believe we're on slide 9. Next slide. Blue Shield is proposing to expand its Trio product to bring an alternative low-cost HMO option into 7 counties: Butte, Kern, Kings, Monterey, Riverside, San Bernardino, and Tulare. It's a mix of rural, central, and southern California counties that have varying levels of plan concentration. The Trio plan is offered in 12 counties for the 2022 plan year. And again, here I want to note that on the original attachment and your board books, the counties of Orange, Santa Cruz, and Stanislaus should be blue because they're offered in 2022, but they are not. But again, the PowerPoint here that we're showing is updated. You have updated maps in your folders, and there are updated copies in the back of the room. This proposal would have a favorable premium impact of $3.41 or a savings of 0.46% off the projected premium. The competition model suggests that the expansion would create modest downward pressure in the expansion counties, and the CalPERS team recommends approval with the acknowledgement that the proposal is contingent on DMHC approval. Next slide.
Just a second, please. Mr. Rubalcaba.
Thank you. I was going to say something earlier, but I think this is a good explanation of how every action that's been recommended is staying with our strategic plan, which is to provide access and quality care. We've always talked about how we need to expand to get competition and get pricing that relates to the quality of care, the cost of care, versus trying to grab the low-risk population. So I commend you on all these proposals, getting the carriers to submit these proposals. Thank you.
Thank you.
Thank you. Ms. Polish?
Next slide, please. Next, let's move to Kaiser. They submitted proposals for a service area expansion, an additional senior advantage product, and a benefit design change. First, Kaiser is proposing to expand their basic and Medicare service area into Monterey County. The provider, specialist, and hospital network will be a combination of Kaiser Medical Group providers, contracted inpatient facilities, and contracted community providers and specialists. This expansion provides an alternative low-cost HMO option with favorable premiums in Monterey County and nominal impact statewide. The competition model suggests that this expansion would be beneficial to the members in Monterey County. CalPERS team recommends approval with the acknowledgement that the proposal is contingent upon both DMHC and CMS approvals. Next slide. Next, Kaiser is proposing to add a brand new Senior Advantage plan with $0 copays for most services except for emergency room, prescription drugs, and our acupuncture and chiropractic benefits. The new Kaiser Permanente Senior Advantage $0 copay plan would be a new plan in addition to the existing Senior Advantage plan and would be made available out of state. The only difference is the $0 copays for most services. Kaiser projects the premium to be about 13.1% more than their current Senior Advantage plan. The chart on the next slide illustrates the 2022 premiums for all CalPERS Medicare plans. Next slide. The chart shown here illustrates the 2022 Medicare premiums and where the Kaiser zero copay Senior Advantage premium would likely fall comparatively. The CalPERS team recommends approval of this proposal. Next slide. Lastly, Kaiser proposes a benefit design change for the existing Senior Advantage plan that would also apply to the new Medicare Advantage plan if approved. This proposal adds a quarterly $70 over-the-counter allowance for members to purchase certain over-the-counter items. Purchases can only be made through a designated website or mail order catalog using a third-party vendor not affiliated with Kaiser. Any unused portion cannot be rolled over to future quarters. This benefit is similar to what's offered by other MA plans and has a projected premium impact of $1.45, which is a 0.48% increase. The CalPERS team recommends approval of this proposal. Next slide. Next, we have a proposal from Western Health Advantage. They propose adding a post-discharge meal delivery benefit to their MyCare Select HMO Medicare Advantage plan. The benefit includes up to 56 meals, 4 times per year following a hospital stay. There are a range of meal options consistent with the hospital's recommendations, and meal delivery coordination would occur prior to discharge. Other CalPERS plans, other MA plans, have similar benefits beginning in 2022. The projected premium impact would be $1.37, which is a 0.44% increase. The proposed changes enhance Medicare Advantage benefits to help keep our Medicare members healthy. The CalPERS team recommends approval.
If you could go back to slide 13, please. Ms. Karen Green Ross has a question.
It wasn't specific to that slide. It was just in general about the DMHC approval process and what the timeline is on that and what you can tell us about that. That was all. And all the-
Unfortunately, we don't have a definitive timeline on DMHC. We hope to know prior to the rate approval process, obviously. So we'll obviously share that out as soon as we get it. But I know that the plans have submitted all of their information. I know they're all very hopeful, but there's not a set timeline on how long it takes.
What we can tell you is that we were able to move the Santa Barbara expansion in a shorter timeline than the one we're talking about now for these plans, but will be a heavy lift. We have good relationship with DMHC, so communication right now is excellent between our organization and that department, and we will do what we can to aid in answering any questions that they have.
I appreciate that. I just also, when you say heavy lift, is it what we were hoping to get is unprecedented for them?
It's more expansions. So EPOs are, my understanding is EPOs are easier because the expectation, they're smaller networks, the expectations are lower. A lot of the network, as Ms. Polish pointed out, are built off of the PPO network, so they're networks that have been in front of DMHC before. Blue Shield is optimistic that they'll be able to move these through DMHC, and we are optimistic as well, or we wouldn't be bringing them forward.
Okay.
Mr. Miller.
Yeah, I really appreciate everything that went into these, and I really appreciate the providing more value for our members and features that they'll like. One of the things that would help me in assessing these is to have a sense of what our expectations are in terms of just the pure quantitative numbers, in terms of our expectations of utilization of, say, we're providing a new benefit. Is it a benefit that 15% of the people in the plan will utilize at some point during the year or 5 years? Or is it something that 0.005% of the members are likely to utilize, just in terms of having a sense of, because the numbers, for me, I look at the numbers and go, oh, X cents a month. Well,
Yeah.
obviously, very, very few people are going to be using this, because if very many of them were using it, it would cost $2 a month or something. So
Yeah.
that would be helpful in future presentations.
So
Thank you.
we're happy to do that. I can tell you, and this may be too much information, so you can stop me if I'm providing too much information. But on a number of the Medicare supplemental benefits, so this is new territory, as we've talked about in this committee before. CMS approved these proposals as part of the Chronic Care Act, and the theory behind them is that these benefits, so the great example is the post-discharge meal benefit, are designed to keep people healthy in very vulnerable times and keep them from being readmitted to hospitals. So we expect over time that we will see returns on some of these investments. We will be monitoring that with our own data. I look at sort of critical time to be making initial evaluation as the upcoming cycle when we're looking at the 5-year renewal for the next HMO contract. When we will make decisions based on our data about recommendations to you all, about which ones should be moving forward and which ones not, and that will largely be based on what we see in that data in terms of secondary effects as well as utilization. The utilization, the less these get used, the lower that per member per month cost is going to be. So if they're not heavily utilized, those numbers go down. As I said before, we can't model some of the secondary effects that we anticipate, so some of the health advantages that we see or even long-term cost savings. If we can't put a hard number on it, it doesn't work into our math, but as we're able to capture that in our data, we'll bring that forward as well.
Thank you. Ms. Polish?
I believe that brings us to slide 15. So that's actually the summary of the health plan proposals, and that will do it for the 2023 health plan proposals. Now I'll turn it over to Dr. Julia Logan to discuss the CalPERS team proposals.
Thank you.
Thank
Dr.
you,
Logan.
Karen. Can you hear me okay?
Yes, ma'am.
Okay. Good afternoon, Mr. Chair, members of the committee. Julia Logan, CalPERS team member. I am pleased to share CalPERS team proposals that we feel align with our strategic plan, promote improved health outcomes, and demonstrate our commitment to health equity. We believe these proposals will drive long-term cost effectiveness and are the right thing to do for our members. This first proposal is a change to the benefit language as it relates to reproductive health equity. This benefit change will improve quality of care and timely access to time-sensitive services, such as cervical and breast cancer screening, abortion care, and sexually transmitted infection screening and treatment. The new language ensures that all members will have timely access and equitable care without undue barriers or delays, regardless of biologic sex, sexual orientation, or gender identity. There's no premium impact with this change, and the CalPERS team recommends approval. Next slide, please. This next proposal updates the definition of infertility to create a more equitable benefit structure for all members seeking these services. The current definition of infertility excludes most LGBTQ+ couples, single adults, and anyone pursuing parenthood outside of a heterosexual relationship. The new proposed infertility definition would expand the availability of fertility benefits irrespective of a member's sexual orientation, gender identity, or relationship status. We anticipate this will have a nominal premium impact, if at all. The CalPERS team recommends approval. Next slide, please. Next, we're proposing coverage of medically necessary and clinically appropriate hearing aids in both ears for members under the age of 26 at 100% coverage every 36 months. Children with hearing loss and deafness often face trouble developing speech, language, and social skills and are at risk for developing depression and anxiety. Studies show that early hearing loss intervention has helped children develop communication and social skills, which in turn promotes academic performance. We bring this proposal to you after a comprehensive review of our current hearing aid benefit. You may be aware hearing aid benefits are part of the discussion at the federal level, including pending FDA authorization of over-the-counter hearing aids for adults with mild to moderate hearing loss, and legislation that includes hearing aid benefits for Medicare recipients. Until this regulatory landscape is clarified at the federal level, CalPERS recommends that we focus the benefit change for 2023 on our youngest members because this benefit change could have a really dramatic impact on this group and because this group of members would not be included in the proposed federal hearing aid regulation and legislation changes. There's a minimal associated premium impact with this change, and we recommend approval. Next slide, please. Finally, the CalPERS team proposes that PPO members are matched with a primary care provider, also known as a PCP, such as a family physician, a general internist, or pediatrician, for themselves and their dependents. This benefit change would not limit choice for our PPO members. If members seek an alternate PCP other than the one they are matched to, they would be free to choose a different PCP. PPO members would still have the flexibility to see any doctor they want and wouldn't need a referral from a PCP, their PCP, to see a specialist. If a member already has a primary care provider that they're comfortable with, they would be matched to that clinician. We bring you this proposal because of our commitment to primary care and after a thorough review of the evidence that consistently demonstrates its effectiveness. Primary care providers are the foundation to patient-centered care. They and their care teams focus on the early detection and treatment of disease, chronic care management, and preventive care. Patients with the usual source of primary care are more likely to receive recommended preventive services like flu shots and other vaccines, blood pressure screenings, and cancer screenings. Research shows that matching to a primary clinician is associated with positive health outcomes and mitigates overall healthcare costs over the long term. This proposal also aligns with the work we're doing to promote primary care, including our Advanced Primary Care Measures pilot and our alignment work with Covered California and the Department of Healthcare Services. There is no premium impact with this change, and the CalPERS team recommends approval. Next slide, please. That concludes my presentation of the CalPERS team proposals we submit to you for approval. I'll hand it back to Karen to talk about next steps.
We have a couple of questions. Mr. Rubalcaba.
Thank you. Dr. Logan, this is very exciting, actually, to try to match with the PCP. How will the match be done? Is it by address or? How would you match them, I guess is my question. I know you understand that they can change any time and they don't have to, they can still go to the PPO because that's what they signed up for, but if you can get them a PCP, it'd be great. But how do you match them? Is it based on address?
Yes, exactly. It's based on location or address, primary language, and whether or not a member has seen that primary care provider in the past. So three things that are really important about primary care are that primary care is comprehensive, it's continuous, and it's coordinated. So it's really important that members continue to see the same primary care provider, and we do not want to disrupt that relationship.
Thank you, and thank you for thinking, also making it cultural sensitive. You said something about, you look at that too, right? Or something.
Language.
Language?
Yes.
That's very important. Thank you very much.
Mm-hmm.
Thank you. Ms. Middleton. Wait, you turned it off. Hold on.
But very heartfelt. I can't tell you how much it means to me to see CalPERS moving forward on fertility care language and the inclusion of LGBTQ members fully. Thank you.
Thank you. Ms. Brown.
Thank you. Doctor, sorry, how often can you, with respect to saying that that you're going to assign a primary care physician, so how often could they change? How easy will it be to change? I really have concerns about that.
Yes, that is very important to us too, to make sure that members feel that they do have choice and they continue to have choice. And so members will be able to change their PCP as often as they choose to do so.
So do they have to go online to do it? Can they call up and do it?
Yes, they'll be able to go online or to call, and we're working with Anthem to make that transition as seamless as possible.
I have Anthem, a PPO, and I have to tell you, the website is terrible, even in terms to just get my medications, let alone to try and get a doctor or change my primary care physician because I've moved, or I don't want to keep seeing my doctor in Orange County or whatever. So it's not that simple. And I really don't think our members with the PPO are going to want that. So, Mr. Chair, I want to know if I don't support that one, but I support the other changes, how is that going to work? Will I just have to vote no on all of 6A? Because it's just one item, is that correct?
Yes.
Okay, thank you.
Thank you. Ms. Polish?
Sorry, reactivate. For next steps, any approved proposals will be incorporated into the 2023 rate development process. Approved changes will be communicated with the health plans, our members, and stakeholders via the appropriate channels. And final 2023 premiums will be presented for approval in summer of 2022. That concludes our presentation, and we're happy to take any additional questions at this time.
Thank you, and thank you both for a great presentation, very concise, a lot of good improvements. We really appreciate that and all the hard work. Seeing no request to speak, it's an action item. What's the pleasure of the committee? Moved by Taylor, seconded by Miller. We have 3 requests to speak from the audience. Mr. Jelinski, while you're on your way down, I'm going to take Ms. Hoig and Mr. Woodson on the phone. Mr. Fox?
Yes, Mr. Chair. We have Stephanie Hugh to go first and Larry Woodson after.
Hi, I am Stephanie Hugh, the President of California State Retirees. Chairman Spector and board members, thank you for the opportunity to comment. CSR is in general support of the health benefits program proposals for the 2023 plan year. We also appreciate staff's earlier public airing of new plans, coverage areas changes, and benefit design changes, as opposed to previous practice of presenting them in June at the same time as the preliminary premium increases are released. This improved scheduling gives stakeholders a much better opportunity to review and comment on them apart from the premium setting process. We also thank the staff for discussing these with us at the stakeholders briefing last week. There were some needed points of clarification on a couple of items, which staff was able to clarify. Mr. Larry Woodson, our Health Benefits Committee Chair, will speak to those in his comments, specifically the matching of PPO members with primary care providers. CSR supports the expansion of plans geographically, although we would like to see better expansion to the 17 rural counties identified in the annual report as having no HMO availability. We also support the positive benefit design changes, and thank you very much.
Thank you.
All right, Mr. Chair, we have Mr. Larry Woodson.
Good afternoon. Larry Woodson, California State Retirees. Chairman Fechner, board members, thank you for the opportunity to comment. As CSR President Hughes stated, we are supportive of all the health benefit program proposals for 2023. They'll give more choices geographically and offer some improvements in benefit design. I would note that while Kaiser, Blue Shield, Anthem, and Western Health Advantage all offer improvements, United Healthcare, while offering some in 2022, are offering none in 2023. Yet, as the chairman will recall, increased their premiums by 8.26% for 2022. So, enough said. Regarding the staff-initiated proposals, we support them, but we do have concerns about the implementation challenge of the PCP match for the PPO plans. The wording of the 6A memo was a little vague on several points, and at stakeholder briefings last week, I was able to get clarification on most of those issues, namely that the matching applies to the basic plans, platinum and gold, and not Medicare supplements, that they apply to both new signups and existing members of those plans. The PCP assigned will be in close proximity to the members of residents, as Dr. Logan mentioned. That's important. A couple of years ago, when Anthem Traditional was first made available to members in Chico, a couple of our members there who signed up and were excited to have another choice got their cards and found they'd been assigned to a PCP in Grass Valley, 75 miles away. So, and that was a hassle for them to get it straightened out. So hopefully Anthem won't make those kind of errors. Since neither Anthem nor CalPERS have an accurate estimate, and I learned this in the stakeholders, of which PPO members actually have PCPs, it appears there may be some confusion there, even though Dr. Logan said those that have them will not be getting a match, and that's good. But it sounds like there may be some that do have them that will get a match, and that will be cumbersome. So the other thing that we learned is that members and their dependents will be matched with the same PCP for those that are matched. That may cause a burden for some members to have to change because covered members may prefer a PCP of the same gender. Another issue I raised to staff was that ensuring the PCP assigned by matching was indeed accepting new patients, because there have been some examples in the past of assignments to doctors or closed practices. So lastly, we are in full support of having primary care providers as a first line of service and treatment, both as a cost savings and reinforcement for quality care. But we do have concerns about some undue burdens to some members. Thank you.
Thank you. Mr. Galincic. Microphone, sir.
Hello?
There you go.
Okay. JJ Jelencic, RPEA. If you choose to live in the beauty and serenity of the forest, you accept the risk of forest fires and should not complain that your homeowner's insurance is higher than it would be in Fresno. If you choose to move near an airport, you should not expect much sympathy when you complain about aircraft noise, unless you're the state controller. I would like to build a ski resort in Sacramento. Unfortunately, the city lacks the essential elements of mountains and snow. I share Don Mold's desire for an HMO in every county. However, the HMO model, like a ski resort, has certain necessary conditions. The HMO model depends on a critical density of population and medical providers. Among other proposals before you is a proposal to expand Blue Shield Access Plus into some very rural areas. No one else has figured out how to make this work. As I said last week, it would be easier to create an HMO for cows than for people in Modoc. It's just a question of critical mass. The system has advocated risk mitigation to protect insurance companies from adverse action or adverse selection, that is, getting stuck with a disproportionately unhealthy population. Last month, the board decided that the focus would be on the cost structure of plans, and the health characteristics of the insured would not be a factor. Several board members expressed surprise, even though it was at least the third time they were voting on the language. Because of the high costs incurred by Blue Shield Access Plus, much of it driven by its willingness to go into rural areas, in 2022, Access Plus will receive $117 per member per month subsidy. Since you were only halfway through the mitigation process, the expectation is that in 2023, the subsidy will be about $230. These subsidies are being paid by members subscribing to more cost-controlled plans. RPEA acknowledges that the proposals are for the basic plans and directly impact very few of our members. However, policies that reward higher medical costs and punish low-cost structures and cost controls will eventually flow through the entire system and impact all our members. Blue Shield has said that it can add these counties with no additional increase in premium. I am, and you should be, skeptical. If you accept the expansion, I would encourage you to add a condition that the higher costs in the expansion area will not be included in the risk mitigation
Time is up, Mr.
calculations.
Jelinski.
Blue Shield should have no objection since it says the premiums will not increase. You may want to consider the same condition for Blue Shield Trio. Thank you.
Thank you. All right, no other request to speak. We have a motion before us. I want to remind the members you're voting for the betterment of all the members of the health system. All in favor of the motion, say aye.
Aye.
Opposed, no.
No.
Motion carries. Anything else on this item, Ms. Polish, Dr. Logan? Thank you both very much for the presentation. Brings us to item 7A, the summary of committee direction. Mr. Molds? Microphone, sir. There you go, you're on now.
Oh, I'm sorry, my book is covering it. It's been a long time, I'm sorry. So I have two directional items. So the first is to look at the percentage of members who are using the acupuncture and chiropractic benefit in the plan, and I believe it's in the Anthem Medicare plan where the changes are being made. And the second is to bring projected utilization where it's available to future discussions when we're talking about benefit enhancement.
Yes.
Yep.
All right.
Great.
Item 7B, public comment. I have a request from David Haxton. Mr. Fox, is that someone on the phone?
Self. Good afternoon. My name is David Haxton. I'm a CalPERS member, having retired 2 years ago after 31 years of state service as a Deputy Attorney General in Los Angeles. My comment is about Medicare Part D premiums, which many retirees pay, but PERS does not reimburse. I just discovered this on the eve of my 65th birthday. With Medicare now contributing to the cost of my health care, I had expected my premium costs to go down, but instead, I will be paying more while the state and PERS will be paying less, much less. That's not right. Medicare Part B is doctor visits and Part D is drugs. Part B has always charged a premium, which recipients pay to Medicare or have it deducted from their Social Security. PERS reimburses these premiums for state and Cal State retirees by adding money to their pension checks up to the retiree's maximum state contribution. Part D didn't become part of Medicare until 2006, and the only premium recipients paid was to the Part D provider, with nothing paid to Medicare. But soon after, to increase Medicare's revenue, Congress began charging higher premiums to recipients with higher incomes. Higher Part B premiums started in 2007, followed in 2011 by higher Part D premiums that were for the first time paid to Medicare. Higher premiums next year start at annual incomes above $91,000. Medicare reports that about 8% of Medicare recipients pay these higher premiums. When the higher premiums were added, PERS reimbursed the higher Part B premiums, but has never reimbursed the Part D premiums. Since both these premiums are for health care, and the state is legally obligated to pay health care costs up to the maximum state contribution, it makes no sense for PERS to be reimbursing Part B premiums, but not Part D premiums. Most of the state and Cal State retirees who pay the higher Medicare premiums will be paying nearly $150 in unreimbursed Part D premiums next year, and some will pay double and triple that amount. The state, on the other hand, saves over $3,000 when a retiree is on Medicare. That $3,000 is what is unused from the maximum state contribution, and therefore is available to reimburse the $150 in Part D premiums. I ask you to direct staff to look at this issue and prepare a report for a presentation at a future meeting. And at that meeting, I ask that you sponsor legislation to amend Government Code Section 22879 to authorize PERS to reimburse Part D premiums. This will allow the many retirees who pay Part D premiums to finally get all the health care costs paid that they are entitled to have paid. Thank you.
Thank you. So that ends our public comment. I do want to take a moment of personal privilege, and since this is Ms. Brown's last PHBC meeting, to thank her for her service on this committee and for offering her input into many of the discussions that we have throughout the year. I also want to remind everyone that this is the holiday season, and especially in these last 18 months, this is a tough time for a lot of families and a lot of people that no longer have families. So think about that when you're out there shopping or seeing people that you interact with on the streets, that they might need a little smile or a little helping hand. So give them that thought and that time during this time of the season, because people need that. With that, this committee is adjourned, and we'll see you in March.
Thanks for coming.
You're back.